Coming up in this episode of Blood and Cancer News, should circulating tumor cells guide treatment in HR-positive, HER2-negative breast cancer? And the FDA approves the first agent for PSMA PET imaging in prostate cancer. And welcome to Blood and Cancer News. Our top story today, Black patients with extensive stage small cell lung cancer are less likely to receive chemotherapy, but they have better survival compared with white patients. This comes from a study published in JTO Clinical Research and Reports. In this real-world study, the researchers identified nearly 150,000 patients who were diagnosed with stage 4 small cell lung cancer between 2004 and 2016. It included over 82,000 patients in the study. Patients were from the National Cancer Database. The researchers found that compared with white patients, Black patients, and patients from other non-white racial groups had lower odds of receiving chemo, with an adjusted odds ratio of 0.85 for Black patients and an adjusted odds ratio of 0.87 for non-white patients of other races or ethnicities. However, the researchers also found that survival was superior among Black patients, with an adjusted hazard ratio of 0.92, and other non-white patients with an hazard ratio of 0.86. Additional factors, such as performance status, which is not captured by the National Cancer Database, might have accounted for better survival for Black patients, according to study author Umid Tapan, MD, from Boston Medical Center. Dr. Tapan noted that the analysis was adjusted for known confounding factors like age, gender, and comorbidities. Black patients had higher odds of receiving chemotherapy between 2010 and 2016 compared with the period between 2009 and 2004. Dr. Tapan said that this suggests a positive impact from the Patient Protection and Affordable Care Act back in 2010. The study published in Academic Medicine back in 2018 showed that 13% of 782 National Institute of Health-sponsored clinical trials reported outcomes by race and ethnicity. Dr. Tapan said that this suggests that there is missing data on patient care in minority populations, and that collecting and analyzing real-world data becomes critical to treatment patterns and outcomes. The current real-world study had a somewhat diverse patient population, but 90.6% of patients were white, 7.8% were Black, and 1.7% were other races. And we move now to trial results that suggest circulating tumor cell counts may be a reliable biomarker for guiding the choice of first-line treatment in patients with hormone receptor-positive, HER2-negative metastatic breast cancer. However, authors of a related editorial suggested that CTC counts are not adequate for guiding treatment choice in this patient population. The results of the Phase 3 study and the editorial were published in JAMA Oncology. In the study, researchers compared the use of CTC counts and the use of clinical factors to guide the decision between chemo and endocrine therapy. They included 755 patients in the per-protocol population with a median age of 63. Among the 377 patients randomly assigned to the CTC arm, those with counts at or above 5 CTCs per 7.5 milliliters received chemotherapy, while those with a lower count received endocrine therapy. The 378 patients in the standard care group received endocrine therapy or chemotherapy based on provider choice, guided by clinical factors. Chemotherapy was given to 37% of patients in the CTC arm and 27% of those in the standard arm. The median progression-free survival was 15.5 months for patients in the CTC arm and just under 14 months in the standard arm, which meant that the primary endpoint of non-inferiority was met. The researchers reported that being older than 60 was the only baseline characteristic associated with better progression-free survival with CTC-driven decision-making. They also wrote that this could be because of greater use of endocrine therapy as the clinically favored treatment.
Go beyond the headlines and hear the full story on Cleveland Clinic's Cancer Advances podcast. It's the medical professionals' trusted source for exploring the latest innovative research and clinical breakthroughs happening in the field of oncology. From the highest profile cancer trials conducted at our research facilities to understanding how they impact your patients, Cleveland Clinic's world-renowned experts take a deeper look. Listen to the latest Cancer Advances episode by visiting clevelandclinic.org/Cancer Advances podcast.
And now for an FDA approval. The FDA has granted accelerated approval for naxitamab to treat certain types of patients with neuroblastoma. The approval was based on response rates in 2 small trials. The approval for naxitamab for use in combination with granulocyte macrophage colony stimulating factor, or GM-CSF, in adults and in children who are 1 year old or older who have relapsed or refractory high-risk neuroblastoma in the bone or bone marrow that demonstrated a partial response, minor response, or stable disease prior to therapy. So let's look at the studies. Both studies were single-arm open-label trials, one of which had 22 patients, the other had 38 patients. In both studies, patients received naxitamab at 3 milligrams per kilogram, administered as an IV infusion on days 1, 3, and 5 of each 4-week cycle in combination with GM-CSF. The overall response rate was 45% in one study and 34% in the second study. The responses were observed in bone and/or bone marrow. The FDA noted that continued approval of naxitamab may be contingent upon verification and description of clinical benefit in confirmatory trials. The agency also noted that naxitamab was granted priority review, breakthrough therapy designation, and orphan drug designation. So what about safety? Naxitamab has a boxed warning about serious infusion-related reactions and neurotoxicity. The product information notes that, in clinical studies, naxitamab has been shown to cause serious infusion reactions, including anaphylaxis, cardiac arrest, bronchospasm, stridor, and hypertension. Infusion reactions generally occurred within 24 hours of completing an infusion, most often within 30 minutes of initiation. Infusion reactions were most frequent during the first infusion in each cycle. The most common adverse reactions were infusion-related reactions, pain, tachycardia, vomiting, cough, nausea, diarrhea, decreased appetite, hypertension, fatigue, peripheral neuropathy, urticaria, pyrexia, headache, injection site reaction, edema, anxiety, localized edema, and irritability. And finally today, a Diagnostic FDA approval. A radioactive diagnostic agent has been approved by the FDA for use in patients with prostate cancer, but only for those treated at 2 specific institutions in California. The product is called gallium-68 PSMA-11. It's the first agent approved specifically for use in PET imaging of PSMA-positive lesions in men who have prostate cancer. Gallium-68 PSMA-11 has been approved for institutional use at the University of California, Los Angeles, and the University of California, San Francisco, under an academic new drug application. The safety and efficacy of gallium-68 PSMA-11 were evaluated in 2 prospective clinical trials with a total of 960 men with prostate cancer, each of whom received 1 injection of the product. The first trial involved 325 patients with biopsy-proven prostate cancer who underwent PET-CT or PET-MRI scans performed with gallium-68 PSMA-11. The second trial enrolled 635 patients with rising serum PSA levels after initial prostate surgery or radiotherapy. All of these patients underwent a single PET-CT or PET-MRI. About 3/4 of patients had at least 1 positive lesion detected by gallium-68 PSMA-11 in at least 1 region. No serious adverse reactions were attributed to gallium-68 PSMA-11. The most common adverse reactions were nausea, diarrhea, and dizziness. And that's it for this edition of Blood and Cancer News. Remember, there are links to every story available in the show notes. Blood and Cancer is produced by MDedge editor Jennifer Smith, and all of our podcasts are produced by MDedge executive editor Kathy Skarback.